of our FDA had become concerned that they were finding an increased suicide rate on studies of Prozac. So they asked Eli Lilly, and this is back now in the late 80s, to go back and look at all of their clinical trials and report to them on the rate of suicide attempts in the controlled clinical trials with the drug versus placebo. Lilly found, depending on how you counted, a 6 to 12 to 1 ratio of suicide attempts, not just thinking, attempts, in the control group compared to placebo. Lilly never made it public. They never gave this report that I found to the Germans. They never made it available to the FDA. I also found memos inside Lilly explaining guilt and shame on the part of some German investigators for Lilly, that the company was classifying suicides and suicide attempts reported by doctors to them as no drug effect or other harmless kinds of entities, thereby disguising the suicide attempts and the completed suicides. And one of these memos, the gentleman declared, how am I going to explain this to my family? It was a genuine shame. At the same time, the FDA conducted a study comparing Prozac to an older antidepressant, trazodone, and factoring in the increased number of prescriptions for Lilly, for Prozac, and also factoring in the controversy, because the controversy hadn't broken out yet. There were far more reports of suicidality, and violence, and other mental adverse effects on Prozac. I worked on these issues for many, many years, as you know, and then testified before the FDA in 2004 on a couple of occasions. And the agency distributed one of my papers written in 2003 to the panel, the FDA panel. And a lot of the language in the current label virtually reads like many, actually very, very similar to what I had to say in these in my papers and books. Now, my conclusions in this testimony are based not only on these very early studies that I discovered inside of Eli Lilly, which, by the way, you can find on my website, the Lilly documents I'm describing, and I describe them in a couple of my books. But my conclusions are based in part on the many citations in the paper I wrote specifically for this committee. I actually sat down and wrote your paper. Antidepressant-induced suicide and violence, risks for military personnel, and in the hundreds of citations in my book. My recent book, which Mr. O was kind to mention, and which I know that you have read, Mr. Chairman, Medication Madness, gives an overview of my clinical experience, which now included in the book more than 50 cases of violence, suicide, and crime, most of them on antidepressants, and I actually interviewed survivors. I actually went to crime scenes, read all the medical records, police records, and clearly documented Medication Madness from a clinical viewpoint that there are many, many cases like this. I actually have over 100 that are mentioned in the book and 50 documented in detail. In 2004, after the various hearings, actually before them, required the antidepressant manufacturers to review their clinical trials. The FDA itself concluded that the newer antidepressants double the rate of suicidal thoughts and behaviors in children, youth, and young adults up to age 24, which of course is very menacing for the soldier population, the military population. Now, you get a doubling of rates. Well, what does this mean? Well, the clinical trials are very short. Most of them average about 6 weeks. Some of the Prozac trials were 4 weeks. Suicidal patients are excluded from clinical trials. The patient is monitored every week by experts and informed of all the dangers, presumably, and the patient is given huge hope. You're in this wonderful research setting where you're getting something new and wonderful. And furthermore, there's no attempt to look for suicide attempts and to categorize them. Now, when you get a doubling of suicide under those conditions, suicide attempts and ideation, under those conditions, you can assume that in the military or clinical practice, it's going to be multiples, unknown multiples, because there it's given for months, there it's not monitored, there psychotic patients are included, there suicidal patients are included, and all of that's excluded from the clinical trials. Now, one of the questions that may come up today is that there were, in this particular batch of trials, no completed suicides. The shock is how many attempts there were, because the best way to treat suicide, if there were one, would be to simply put somebody in a clinical trial and give hope, because suicide is loss of hope. And that's why when you get all the doctors looking at you and testing you and working with you, you almost never get suicides in any kind of clinical trial of that kind. Now, the FDA warnings that came out of these hearings are identical for all antidepressants. The Zoloft label is the model I'm going to use. And it begins with a huge black box, very rare thing, with the title Suicidality and Antidepressant Drugs. And I'll read you just the first line of it. Antidepressants increase the risk compared to placebo of suicidal thinking and behavior, parentheses, suicidality, in children, adolescents, and young adults in short-term studies of major depressive disorder and other psychiatric disorders. And later in the label, they'll say that a lot of the adverse effects occur in non-psychiatric patients. This black box is very lengthy, and many of the items are repeated over and over again. It's the only label like that that I know of. The black box is followed by a very ominous section, still in the warnings, entitled Clinical Worsening and Suicide. This idea of clinical worsening that's repeated in the label is not given enough attention. It states in this section that the following symptoms I'm going to list, quote, have been reported in children and adults taking antidepressants, both for psychiatric and non-psychiatric purposes. And the list includes anxiety, agitation, panic attacks, insomnia, irritability, hostility, aggressiveness, impulsivity, akathisia, which is psychomotor restlessness, and the DSM-4, our major document, points out that akathisia leads to violence and suicide. So I interrupted. Akathisia, hypomania, and mania. And mania is an out-of-control state that increases vastly the risk of violence and suicide. This is the list that's virtually taken from several of my earlier publications. And note the mention of irritability, hostility, aggressiveness, and impulsivity. Imagine causing that in young men and women who are heavily armed and under a great deal of stress. And irritability, hostility, aggressiveness, impulsivity not only lead to violence but to suicide. Many suicides are out of anger and irritability and resentments.
Dr. Bregan, if I don't mean to interrupt, I just want to ask a specific question. If say an active duty soldier is given these medications, they may not even see that warning, right? I mean,
well, my experience, last year I spoke at the oldest military stress conference given. Bart Billings, whom you know, a retired Army officer and psychologist, runs that. And I talked to generals and I talked to mental health professionals, and they all agreed that these warnings were hardly ever presented to the soldiers, and that the Army was, in a sense, acting as if it was unaware. And some of these people gave me estimates, not of the 15% on psychiatric drugs that we often hear, but up to 30% of soldiers in some sections. Marines in particular was one that was mentioned to me.
So they're not even informed of the risks?
No. And as we go on further, we'll see that the FDA tells doctors you should, and the word should is in the label, you should share this information with the patient and the family and make sure they understand it. It's not just you repeat it to them. You sort of, hey, I want you to understand, this is what may happen to you. That's what I do in my clinical practice. I don't say, by the way, the drug may cause this or that. I just make sure over a period of many sessions that the person understands the risks. Now, did I answer the question, sir? In addition to this, this list that's associated with the drug itself, the antidepressants, and this is mentioned in the label and in the mentioned in the medication guide I'll tell you about, the antidepressants often cause severe withdrawal reactions in which all of those symptoms, all of those adverse reactions can develop. In fact, I spend probably half my practice, even in remote Ithaca, treating people who come to me to try to get off of these drugs and are suffering violent feelings, suicidal feelings. And in fact, in the last 3 weeks, I've had at least 3 or 4 patients who, as we went down lower on their doses, developed really, really frightening reactions, and then I had to treat those, usually by raising the dose back up for a while. Let me mention some of the science more specifically at this point. This list of mania and hypomania and agitation and aggression and so on, that list in one FDA document is stated to be a known effect, this whole series that I read to you, a known effect of the drugs. And what I'm going to read to you now involves mostly controlled clinical trials or epidemiological studies. No one should be able to say that causality has not been demonstrated. The gold standard for causality is the controlled clinical trial, and it shows a doubling of the rate of suicidality. That's the gold standard. And I have a discussion that's documented between the top members of the FDA agreeing at the hearings that unless somebody's cheating or there's some other malfeasance going on, when you have a causal association in controlled clinical trials, and I would add, they weren't discussing this, epidemiological studies, that's causality. In addition, federal regulations say that the warnings label must have a reasonable degree of certainty about causality before it gets put into the label. An overview of some of the studies that are involved, because I want you to know this isn't my personal opinion. This is what the science has overwhelmingly taught me, starting with my looking inside the drug companies. In addition to the studies done under the auspices of FDA, we have, and this is for children and adults, we have a study by Aursnes, A-U-R-S-N-E-S, in 2005. He looked at 16 placebo-controlled clinical trials in which Paxil was randomized against placebo and found increased suicidal behavior. The references are in the article that I gave to you, as well as my books. Ferguson in 2005 searched the adult literature, found 702 randomized clinical trials with 87,000 patients, and found a significant increase in suicidality on antidepressants. Donovan in 1999, in a large British study involving 229 completed suicides, it's a big study in England, found a higher suicide rate in patients treated with the newer antidepressants. Donovan in 2000 examined 2,776 consecutive cases of deliberate harm in individuals aged 17 and older, not children, 17 and older, like soldiers, seen at the emergency department of a British infirmary. Again, the suicide rates were increased in people taking the newer antidepressants. A fellow named Jick, J-I-C-K, in 1995, conducted an epidemiological study in the United Kingdom involving